So anemia is a condition in which the present hemoglobin in the blood is 2 standard deviation below the mean for age and sex. Okay. And there is a physiological definition of anemia as well. It is a condition in which tissue hypoxia occurs due to inadequate oxygen carrying capacity of the blood. There was a survey, that is National Family Health Survey, NFHS 5. It has shown that about 67.1% of the children between 6 months to 59 months, they have anemia. So this table has been taken from OPGHI textbook of Pediatrics. I have made all of my slides from OPGHI textbook. So you will be able to go through the chapter simultaneously even if you like. So this is a table, it shows the hemoglobin and the hematocrit in infancy and childhood. So to start with birth, cord blood mean hemoglobin is 16.5, mean minus 2 standard deviation is 13.5. Therefore, anemia is when the hemoglobin is below 13.5 gram per dl. And the corresponding hematocrit is 51 and 42. Coming down to girls 12 to 18 years and boys 12 to 18 years, the mean being 14.0 and 14.5, and anemia is, we call it anemia when the hemoglobin is going below 12 and 13 respectively. These are the World Health Organization cutoffs. Here you can see we are mentioning the age groups. 6 months to 5 years, anemia is when the hemoglobin is less than 11 and hematocrit is less than 33. Children 5 to 11 years less than 11.5. Children 12 to 13 years less than 12. Non-pregnant women less than 12. Men less than 13. You will have to learn this. These are very favorite questions during Viva. The hemoglobin percentage at which we consider that the patient is suffering from anemia. Now we will learn about the approach to anemia. What do you mean by approach? Approach is first history taking, then examination of the patient, then doing the relevant investigations and reaching a diagnosis. So suppose an infant, who is an infant? From birth to 1 year of age. An infant is presenting with anemia. What history? We will have to start with the obstetric history. We will have to ask whether the mother was also suffering from anemia, what was the cause, whether there was any blood loss, collagen vascular disease, infections, drug intake which may be responsible for causing anemia in the mother. Perinatal history is also very important, whether the baby was born prematurely. There is a condition called anemia of prematurity in which premature babies are more prone to develop anemia. Whether there was any perinatal blood loss, for example, in gynae lectures you will learn about placenta previa, abruptio placentae, where there is blood loss, significant blood loss, and the newborn may suffer from anemia. Neonatal jaundice may be due to AB or RH incompatibility, G6PD, the glucose 6-phosphate dehydrogenase enzyme deficiency, or sepsis, whether there was any hemangiomas, cephal hematoma. What is cephal hematoma? There is collection of blood. There is subperiosteal blood collection. So there is blood loss and the baby will have anemia. Same for hemangioma. It's a vascular malformation. Much amount of blood is remaining trapped inside the hemangioma. That is remaining outside the circulation. So the baby will have anemia. This is a very important question. What was the age of onset of anemia? Physiological anemia, it occurs at around 2 months of age. And in thalassemia major, the anemia will present average at 9 months of age. Why? Because up to 6 months, maternal hemoglobin is helping the baby. After 6 months, the maternal hemoglobin will cease to exist in the circulation. The baby will have to use up its own hemoglobin, and at that point of time, the child presents with anemia. So around 6 to 12 months of age, a baby with teenager will present with anemia. What is diamond black fan anemia? Diamond black fan anemia is a condition. This is the first class of hematology. In the subsequent classes, you will learn about different types of anemia. At that point of time, you will hear about diamond black fan anemia. That is an inherited bone marrow failure syndrome. When the bone marrow is not working, that is not going to work from birth only. So the baby will have anemia from newborn and even infancy. Okay. Dietary history is very important. What the baby was eating, that is whether the baby was breastfed, for how long the baby was breastfed, because the iron which is present in breast milk is more bioavailable to the baby. Whether the baby was on formula or cow milk, there will be iron deficiency. Cow milk allergy, this is a very common entity. What happens, the baby's gastrointestinal tract reacts to the protein present in the cow's milk and there will be GI bleeding. So because of the bleeding, blood is getting lost from the body and therefore the baby may show symptoms of anemia. Goat milk has folic acid deficiency, and whether the child was on any vitamins and hematinics like iron supplements, and adequacy of weaning. What is weaning? You have been taught about this in the nutrition class. Like now we don't use the term weaning. We use the term, what term we use after breastfeeding, what starts? Ekjon bol? Complementary feeding, yes. Weaning kothata ekhon uthe geche, thik ache? To how adequate the complementary feeding was, thik ache? If it was not adequate, the baby will have the nutritional deficiency anemia. Other points which we'll have to ask is whether the baby was suffering from any fever, infections, whether the baby had jaundice, which may be persistent jaundice, intermittent jaundice, whether the baby had developed gallstones. Ei pointer gulo khub important. When you'll be taught about this hemolytic anemia, then you will learn why the point of jaundice is so important. Whenever RBC is breaking down in the circulation, bilirubin is going to increase and that is leading to jaundice. Whether there was any chronic illness, whether the baby was on any drugs, family history of problems in other siblings, because there is some hematological problems like thalassemia, hereditary spherocytosis, they may run in the families because of the genetics. Inherited bone marrow failure syndromes. One name I told, diamond black fan syndrome. There is another term called Fanconi's anemia. These babies will present with growth retardation, dysmorphic features in the body. Now coming to young children. In young children also we will inquire about the diet, timing of the complementary feeding, nutritional quality of the foods given. Pica. What is pica? কি হয় পাইকাতে কি হয়? Yes. So pica, if you eat soil, what will it contain? Worms, infections. There will be infestation of the gut with the parasites. So they will eat up. They can cause GI bleeding and that can lead to anemia. Okay. Then again worms, epistaxis, hematuria, any acute illness the baby is suffering from. Malaria. Malaria is a very common cause in this tropical country. It causes anemia. Okay. And tuberculosis, our national disease. It is a very common cause of anemia of chronic disease. Okay. Then transient erythroblastopenia of childhood. It is a very transient condition. In childhood, where the erythroblasts are present in the bone marrow. It is a transient condition where the erythroblasts are decreasing in the bone marrow. So erythropoiesis is not occurring properly. So the RBC count is less. So there will be anemia. Family history of thalassemia, sickle cell disease, any other hemoglobinopathies, jaundice again, early onset gallstones, leg ulcers. Leg ulcer is commonly found in sickle cell disease, hemolytic anemia. History of recurrent blood transfusions in hemolytic anemia, membranopathies, enzymopathy. Membranopathies are, you will be taught about this hereditary spherocytosis. It's an important condition. Enzymopathy means G6PD deficiency, pyruvate kinase deficiency. Then congenital dyserythropoietic anemia, this is a very difficult entity. Just learn ki there are some mutations, dyserythropoietic, abnormal erythropoiesis, RBC not getting formed properly, that is why there is anemia. Then some anemia of chronic disease as in chronic kidney disease and juvenile rheumatoid arthritis. These are some chronic diseases will cause an inflammatory condition in the body, there will be anemia. Medications like anticonvulsants, ACI, anti-cancer drugs and lead toxicity. Lead toxicity occurs from the use of lead based paints and some chemicals which contains lead. In the adolescents again we will inquire about pica, any infection, infestation, acute and chronic illness, autoimmune disorder, this is very important, SLE, rheumatoid arthritis, autoimmune disorders they have onset during adolescence very commonly, adolescent females are very commonly affected by this. And diet, অনেকেই diet করে adolescent period এ, totally vegan, so they will have vitamin B12 deficiency, folic acid deficiency, iron deficiency or ketogenic diet, that is also another type of diet where they consume very less amount of carbs. Now coming to the clinical features. One or two words about the pathophysiology of anemia. What happens? When the hemoglobin of the blood is falling, some compensatory mechanisms will happen in the body. What will happen? The stroke volume will, body will do something, the stroke volume will increase. What is the function of hemoglobin? It supplies oxygen to the tissue. So my tissues should get oxygen. There is less hemoglobin. Body will say, I will supply more and more blood to the tissue. There will be hyperdynamic circulation. The blood flow velocity, the plasma volume will increase, stroke volume will increase, cardiac output will increase. At the same time, because of these things, the patient will show symptoms of hyperdynamic circulation in the body. So, because of less hemoglobin, there will be tissue level hypoxia, and because of the tissue hypoxia, these symptoms will appear. The point, the hemoglobin at which the symptoms are going to appear depend on the cardiovascular status of the patient and also the rapidity at which the hemoglobin is declining. For example, if a child has met, God forbid, with a road traffic accident, there is acute loss of blood from the body. The rapidity at which the hemoglobin is falling is so high that the symptoms of anemia will start at even a higher hemoglobin. But in a chronic patient, the symptoms will appear at a lower hemoglobin. Okay? Now starting with the symptoms, very commonly the most common and earliest are tiredness, lassitude, easy fatigability, generalized muscular weakness. There will be poor feeding, irritability, poor school performance, exertional dyspnea, tachycardia, palpitation. Why exertional dyspnea, tachycardia, palpitation? Hyperdynamic circulation, there is stress on the cardiovascular system, the heart is pumping more and more, it is overworked, that's why. And then we have the CNS symptoms, less amount of blood going to the brain, that's why CNS symptoms are appearing. In the form of dizziness, headache, humming noise in the ear, tinnitus, fainting, poor concentration, drowsiness, clouded consciousness. Each and every word has been taken from Ghai textbook. Everything is taken from there. So this is a diagram, just see the symptoms. CNS symptom, fatigue, dizziness, fainting, muscular weakness, shortness of breath in the respiratory system, intestinal change stool color. If there is blood in stool, there will be black tarry stool. Okay? Blood vessels, there is low blood pressure. Eye yellowing because of the icterus. Heart palpitation, rapid heart rate, chest pain, angina, heart attack. And skin paleness, coldness, yellowing, and there will be spleen enlargement. So in severe anemia, we are going to get this chest pain, angina, heart attack, the severe cases. Now we come to the clinical examination. Pallor is the most important clinical sign. Pallor কিভাবে দেখে? কে বলবে? পেছনে জিজ্ঞেস করব। ওই লাস্টে black t-shirt পরা বল। Sites of examining pallor in a child. Lower palpebral conjunctiva, then tongue. Tongue এর কোন surface? Dorsum or under surface? dorsum, then nail beds, oral mucosa, ঠিক আছে? ঠিক আছে. So pallor is the most prominent sign. We examine the nail beds, oral mucosa, lower palpebral, conjunctiva. Now there is another point, very commonly we see the palm, but in very small children it may not be reliable because the skin pigmentation is not proper in very small children. Okay, so observing palmar creases and skin pallor is insufficient in children as the skin creases are not pigmented. Another thing is facial pallor. The skin may not be pigmented in small children, and also if there is facial edema because of any pathology, edema will make the skin look pale, as happens in nephrotic syndrome. Okay. Then again on cardiovascular system you are going to get hemic murmur. What is hemic murmur? It is a mid systolic flow murmur. It is best heard in the pulmonary area, but it is audible over all areas, and that is heard in severe anemia. Whenever you will see thalassemia patient coming to you for blood transfusion, hemic murmur is present in all the patients. Okay. Heart failure in very severe anemia, systolic bruit. It is a condition, it is a clinical sign which is found in hyperdynamic circulation. In the major arteries you will hear systolic bruit. And postural hypotension, elevated pulse pressure and a collapsing pulse in severe anemia. এটাও খুব clinical sign. In the cardiovascular system clinical examination you will be taught about how to examine a collapsing pulse. Okay. Now this is a picture, palmar pallor এর একটা picture আছে. This is an adult picture actually. You can see this is a pale palm and this is a normal palm. Just see, you can't even see the palmar creases here. So the skin as well as the palmar creases have just merged, but here you can see the palmar creases so prominently. This is the lower palpebral conjunctiva, pale. Okay. Then this is tongue. In mild, moderate, severe pallor the tongue is totally white almost. See. Then ECG changes. These are some further cardiovascular examinations. ECG changes will be found in 30% of the patients with hemoglobin less than 6 gram%. You find normal QRS complex, depressed ST segment, flattening or inverted T waves. Now clinically examining, keeping in mind all the other causes of anemia, if you clinically examine a patient, the systemic examination, you may find abnormality of the radius of our hand, found in Fanconi anemia, thrombocytopenia absent radius syndrome. These are all inherited bone marrow failure syndromes. Splenomegaly in hemolytic anemia, infection, storage disorder. Name one storage disease. একটা নাম তো তো এমসিকিউ করছিস, গচার ডিজিজ। Lymphadenopathy and hepatosplenomegaly found in malignancy or infection. Petechi, purpura, Petechi can be found in leukemia patients also. Then icterus in hemolytic anemia, bossing, thalassemia class e hobe frontal bossing pabe. ঠিক আছে. Now we come to the laboratory investigations. Hemoglobin is low. Red cell indices, 3টে red cell indices, mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration. So mean corpuscular volume, based on it anemia can be microcytic, macrocytic, normocytic. What is normal MCV? 80 to 100 femtoliter. MCV less than 80 is microcytic, MCV more than 100 is macrocytic. And based on MCH and MCHC, it can be normochromic or hypochromic. We are also going to see RBC morphology on the peripheral blood smear, whether there is any schistocytes. Schistocytes কোথায় পাওয়া যায়? Condition আছে hemolytic uremic syndrome, microangiopathic hemolytic anemia, ওগুলো later classes এ হবে. And RBC polychromasia, RBC এর মধ্যে malaria parasite ও দেখতে পারো. You can see malaria parasite in the RBC also. This is a table where the normal values are mentioned. MCV normal I have told, MCH is measured in picograms. It's around girls and boys between 12 to 18 years, it's 30, and mean corpuscular hemoglobin concentration, it's around 34. What is RDW? Red cell distribution width is, we are seeing the different sizes of RBC in the peripheral blood. More the diversity or the different size of RBCs in the peripheral circulation, more will be the red cell distribution width. So, anisocytosis. What is anisocytosis? Different sizes of RBCs are present in the peripheral blood. So, RDW will be more in iron deficiency anemia. It will also be more in thalassemia, but it will be more in case of IDA. And again, serum iron, normal values are 60 to 170 microgram per dl. Ferritin normal is 100 nanogram per ml in boys and 40 in girls. Total iron binding capacity, what do you mean by it? Just say the name, it is total iron binding capacity. If I am going to have deficiency, my body needs more and more iron, so my capacity of binding iron will be more. Then transferrin saturation, normal transferrin saturation is 20 to 50%. What do you mean by that? What is transferrin? Transferrin is a carrier protein, it binds iron. So, when I have less iron in the body, the transferrin will be less saturated. So, normal is 20 to 50, if it is less than 20, there is iron deficiency. These are when we suspect a patient having iron deficiency anemia, we actually send iron profile in the patients. What is iron profile? Serum iron, total iron binding capacity, serum ferritin, and this one, transferrin saturation. Okay. What is reticount? Reticulocytes are what? Small RBCs, but nucleated, okay, though are the premature RBCs. In the steps of erythropoiesis, you have learnt about what is reticulocyte. So, reticulocyte count is very important. It will help us to differentiate whether the anemia is because of destruction of RBC in the peripheral circulation or it is because of decreased production of RBC in the marrow. Is it a marrow cause or it is a periphery destruction cause? Okay. Now, there is a term called corrected reticulocyte count. Corrected reticulocyte count, two formulas are there. Reticulocyte percentage into hemoglobin by 15 or reticulocyte percentage into patient hematocrit by normal hematocrit. When the hemoglobin is normal, reticount is 1 to 2%. This is very technical. The formula is a bit difficult. Since it is mentioned in OPGHI textbook of pediatrics, I have made a slide out of it. Otherwise, I wouldn't have mentioned it in the class. Okay, you will have to mug it up. No option is there. এই তিনটে অ্যাপ্রোচে চার্ট দেখাবো ওপিঘাই থেকেই নেওয়া তো পেছনের লোকরা দেখতে পাবে না I will just spell it out, just hear it, then go to the hostel and read it from the book. My approach to microcytic, normocytic and macrocytic anemia. This is a very favorite question in the MBs. Okay. Now, approach to microcytic anemia. Whenever we are getting microcytic anemia, we will perform a peripheral blood smear, do a reticount, do the iron studies. Normal or reduced reticount, we perform iron profile. Low serum iron, low ferritin, increased TIBC means iron deficiency anemia. If there is low serum iron, normal or high ferritin, normal or low TIBC, we perform ESR, that is erythrocyte sedimentation rate, and C-reactive protein. Elevated means inflammatory disease and normal means anemia of chronic disease. If there is normal or increased serum iron, normal or low TIBC and ferritin, hemoglobin electrophoresis or HPLC is to be done. If HPLC is abnormal, it is hemoglobinopathies. Example, thalassemia, beta major, beta minor, alpha thalassemia. If HPLC is normal, it may be sideroblastic anemia. Then increased reticount, abnormal red cell morphology, HPLC is to be done. It may be hemoglobinopathy, sickle hemoglobin, SC, S-beta thalassemia. Then in case of normocytic anemia, when the mean corpuscular volume is 80 to 100 femtoliter, again we will perform a reticulocyte count. So, reticulocyte count, normal or reduced, we perform serum iron. Iron low means it can be anemia of chronic disease or early iron deficiency or mixed nutritional deficiency. If serum iron is normal or high, bone marrow biopsy to be done. So, bone marrow biopsy te ki pete pare? Infiltrative disease by leukemia, metastasis, myelofibrosis, aplasia, pure red cell aplasia, myelodysplastic syndrome, congenital dyserythropoietic anemia. And we will also screen for renal, hepatic and endocrine diseases. If negative, we do bone marrow biopsy. If positive, we will consider it to be anemia of kidney, liver or endocrine disease. If the reti count is increased, we will, and if we find that there is hemolysis occurring, so it is coming under hemolytic anemia, we will do classes on hemolytic anemia, okay. And if the hemolysis test, and what do you mean by test for hemolysis? Coombs test, if it is positive, it is autoimmune hemolytic anemia, LDH is raised, urobilinogen is raised. So, the hemolysis has its markers. If there is no hemolysis, we will consider that there is hemorrhage occurring or there is recovery phase from nutritional deficiency or sepsis, that is why the reti count is increased, but it is normocytic. Then macrocytosis. Macrocytosis, big RBCs you are finding in the peripheral blood smear, it is more than 100 femtoliter in volume. In peripheral smear, we are getting macrocytes, we get hypersegmented neutrophils, 6-lobed. Yes, megaloblastic anemia will be taught in the next class itself. There we will show the pictures of the peripheral blood smear. So yes, it is megaloblastic anemia in which the levels of vitamin B12 and folic acid will be low, and on bone marrow examination we will get megaloblastic changes. Okay. If there is no megaloblastic change, we will have to find out other causes of macrocytosis like hypothyroidism, phenytoin or 6-mercaptopurine intake, congenital deficiency of transcobalamin 2 or intrinsic factor, cyanotic congenital heart diseases, Down syndrome. If you find there is no we are not thinking about megaloblastic anemia, we will perform a reti count. Reti count decreased means we will test the liver function and thyroid hormone. And if reti count is increased, again we will think it is hemolysis or hemorrhage. When we are not able to find out any causes, we will do bone marrow aspiration. There we can find aplastic anemia, pure red cell aplasia, congenital dyserythropoietic anemia, sideroblastic anemia, myelodysplastic syndrome. Please go through these tables from the book today only, because these are quite difficult. These 3 slides are the most difficult slides in today's class. You will have to learn the concept, then only you will be able to replicate this in the examination. This will be asked during MBs. It is a very favorite question. Now, etiology of anemia based on the corrected reti count. So, conditions where reti count increased, where reti count decreases. So, it has been taught in the previous slides also, just naming them. Low reti count in aplastic hypoplastic anemia, transient erythroblastopenia of childhood, pure red cell aplasia. So, when the causes are affecting the bone marrow, so the reti count will be less. Parvovirus B19 infection, vitamin B12, folic acid, iron deficiency, infiltration of the bone marrow, as well as cancer chemotherapy, serious infections, radiations affecting the bone marrow. And you will get high reti count in hemolytic anemia itself, there will be high reti count, as well as in sepsis, hemorrhage, splenic sequestration. This occurs again in hemolytic anemia, splenic sequestration occurs in sickle cell anemia. Recovery from deficiency of iron, vitamin B12 or folic acid, and systemic sepsis. Now we will briefly learn about iron deficiency anemia. This is the most easy anemia to learn about. Okay. What is iron deficiency anemia? Iron deficiency anemia is that anemia which occurs because of deficiency of iron. Why there is iron deficiency? Decreased dietary iron, you are not eating green leafy vegetables, you are not eating meat as well as fish, you are not eating the food which are rich in iron, and reduced iron absorption in proximal small intestine. Like if there is presence of phytate, phosphate, tannic acid in the food, that will interfere with the absorption of iron from the proximal small intestine. And when there is excessive loss of body iron, that happens in GI bleeding. Okay. And hookworm infestation, malaria, that can also lead to bleeding. With blood, iron is lost, so there will be iron deficiency. Cow milk. Cow milk contains what? High amount of calcium. So this calcium will actually compete with iron for absorption. So more calcium means less amount of iron absorption from the gut, that is going to cause iron deficiency. Again, cow milk protein allergy, I have told before in the previous slide, cow milk protein allergy will lead to GI bleeding, that is why there will be anemia. So causes, in a picture you see blood loss, malabsorption, gastrointestinal conditions and not getting enough iron in the foods, green leafy vegetables and meat. Okay. Why iron is important in our body? Iron is important for the oxygen transport, DNA synthesis, electron transport. There are many enzymes which contain iron as a cofactor. So those enzymes are not going to work properly. And immune function, tissue function. What is the amount of iron in healthy newborn? It is about 250 mg of total body iron, around 80 parts per million, and it decreases to 60 parts per million in first 6 months. Here we have the national program of iron supplementation. There is an Anemia Mukt Bharat and the National Anemia Control Program. I thought to include it in this class, but today the slides are quite lengthy, that is why I have not included that topic in today's class. I will be teaching that in the next class. So since around 6 months iron decreases, hence the importance of supplementing iron from 6 months of age only. We will start supplementing iron in babies from 6 months because the physiological iron is declining. Okay. Now again clinical evaluation we will start from diet, type of milk, breast milk iron is more bioavailable than cow milk, what was the food the baby was getting during complementary feeding, any iron supplements the baby was taking, pica, because pica causes helminth infestation and lead poisoning. Then there will be irritability, anorexia followed by weakness, fatigue, leg cramps, breathlessness, tachycardia in case of severe iron deficiency. Congestive cardiac failure, splenomegaly in severe persistent untreated iron deficiency anemia. And there is also angular stomatitis, glossitis, Koilonychia, Platinichia. What is Koilonychia? Anyone? Spoon shaped nails. What is Platinichia? Flat. Very good. So these are the symptoms. So what symptoms you see in the picture? Shortness of breath, fatigue, heart palpitations, poor focus, restless leg syndrome, headaches. Okay. This is Koilonychia. Excuse me. Spoon shaped nails, angular stomatitis. Okay. Again we come to the laboratory diagnosis of iron deficiency anemia. Again we will do a peripheral blood smear. What will you see? Microcytic, hypochromic RBCs. Anisocytosis means different size of RBC. Poikilocytosis means different shapes of RBCs. Increased red cell distribution width and RBC count will be reduced. So RBC count is increased in thalassemia. There is a very famous table given in Ghai only. It will be shown in the thalassemia class ki how to differentiate between iron deficiency anemia and thalassemia trait. These 2 points are important. RBC count, that is decreased in iron deficiency anemia, but that is increased in thalassemia. And this one, red cell distribution width, it is more in iron deficiency anemia, but it is less in thalassemia. Serum iron is bound to be low, there is no iron in the body. Total iron binding capacity will be raised and transfer in saturation will be less than 16%. The earliest marker is serum ferritin reduction because serum ferritin is the storehouse of iron in the body. So when in the beginning only serum ferritin will first decline, then when the ferritin is over, ferritin stores are exhausted, then the serum iron will start to decline. Then this is a term, this is a free erythroprotoporphyrin. What do you mean by protoporphyrin? Just remember the biochemistry class on hemoglobin structure. Those are protoporphyrin rings, no? If the protoporphyrin rings are not having iron, they are only erythrocyte protoporphyrin and they are freely roaming in the body, they do not contain any iron. So if we measure even that, this is an expensive investigation obviously, we usually do not do this for text purpose. Free erythrocyte protoporphyrin will be high, they have no iron in them. This is the peripheral blood smear picture, just follow the pointer. See the RBC, they are smaller in size and the central pallor is more. Look at this RBC, kotota shada bhitorta. So it is hypochromic and it is microcytic as well. Here also central pallor inside the RBC is so big. So there is huge, this is hypochromic. And how do you find out whether the RBC size is less? The pathologist, what they do, they compare the size of the RBC with the nucleus of a small lymphocyte. If it is very small, this is a lymphocyte and this is the nucleus of the lymphocyte, the violet one. They just compare the size of this RBC with the lymphocyte. It is so small and it has got a ring of central pallor inside it and the hemoglobin is just like a thin ring. So this is obviously a microcytic RBC and hypochromic as well. Now we come to treatment. Treatment is very easy. Give this food. This contains more amount of iron, fish, eggs, fresh vegetables, oral iron supplements. If oral iron supplement is not working, we go for parenteral iron infusion. So first it begins with dietary counseling, then treatment of the underlying cause, and we give oral iron. Oral iron, there is a preparation called ferrous sulfate that is very cheap and that is very easily available and that is very effective as well. And it contains 20% elemental iron. The timing of taking oral iron is it should be taken on an empty stomach. But usually if you take it on empty stomach, it causes gastric irritation. So what we say, take it between meals. Like you had your lunch, take it about 2 hours after having your lunch. And 10 to 20% of the patients will have nausea, epigastric pain, discomfort, vomiting, constipation, diarrhea. These are some side effects which can happen in a patient who is getting oral iron supplementation. What is the dose? It is around 3 to 6 milligram per kg per day of elemental iron. To reduce the side effects, enteric coated tablets have been manufactured. But enteric coated tablets are more costly and they have less efficacy also. This is a very important question. What is the duration of therapy of the iron supplements? In some books 3 months is mentioned, but in OPGHI textbook 4 to 6 months is mentioned. That's why I have written 4 to 6 months. In some MCQ books 3 months is given as options. 4 to 6 months after correction of anemia to replenish iron stores. It should be given because we don't only want to increase the serum iron level, we also want to replenish the ferritin which has got exhausted in the body. What are the indications of parenteral iron? Parenteral iron will be given only when there is intolerance to oral iron or the child is having any malabsorption syndrome, the gut is not absorbing the nutrients well, like the inflammatory bowel disease, those things. And ongoing blood loss at a higher rate, huge amount of blood has been lost from the body, you can't replenish it by taking oral supplements, you will have to give something intravenously. This is again a very difficult table, it is given in GHI, I have included it, how to calculate the dose of parenteral iron, it is more of a pharmacology slide, okay. It was not in our syllabus, when we learned this was not included, now it is included, that is why you will have to learn it. You may be asked about this. So how to just, to be simple and how to remember, how to calculate the dose of iron, we will have to, there is a formula by which we find out what is the total iron deficit in the body. What is that formula? It is target hemoglobin minus actual hemoglobin multiplied by weight into 2.4 plus 15 into weight. You will have to learn this, mug it up. So by this formula we will calculate this is the iron deficit in the body and this is the iron we will have to administer to this patient. And now I have got a figure and I will divide that dose into few doses and I will administer it every 3 to 7 days. Recommended maximum dose single we can give is 300 mg. In one sitting we can give 7 milligram per kg body weight of iron or 300 milligram, not more than that. Why? Otherwise there will be adverse effects. Now how do you administer it? Do you know about test dose? Before any IV injections, we usually do a skin test. That is called the test dose, whether the child is showing any reactions or the child is having any allergy. If we do not do skin test, the child may land in anaphylactic shock. That is the importance of doing test dose. Now suppose I need to give a dose of 100 milligrams. I will have to dilute it 1:1 with normal saline, equal volume of normal saline and dilute column. Then I will infuse it over 30 minutes. If the dose is 100 to 200 mg, equal volume dilution in normal saline, but infuse it over 60 minutes. If the dose is 300 milligram, dilute it in 250 ml NS, infuse it over 90 minutes. So the maximum time is 90 minutes. Now, why is parenteral iron needed? Because it is safe and effective. Once it is entering the circulation, immediately it is starting to work. There is no need to get absorbed from the gut. Okay. Two preparations, iron sucrose and ferric carboxymaltose. Iron sucrose is the cheaper one. It is most commonly used. And it is, what are the indications? Suppose a patient is on hemodialysis because of advanced chronic kidney disease. In that case, what happens in chronic kidney disease? There is anemia. Why? Because of decreased amount of erythropoietin release. It is an anemia of chronic disease. So we need to give parenteral iron in this patient, and also in inflammatory bowel disease. So what is the dose? It is 1 milligram per kg per session of hemodialysis and 1 to 2 milligram per kg per week of hemodialysis. Again, that is also being diluted and given over 90 minutes. Ferric carboxymaltose, this is a new preparation. It is a bit expensive, but the dose is less. It is a single dose thing. We do not need to give over repeated sessions. So it is approved in malabsorption. The dose is either it is 15 milligram per kg or maximum it is 1 gram, that is 1000 milligrams. Now whenever a patient is on iron therapy, we expect that the hemoglobin will rise by 1 gram per dl every week. If it is not rising by 1 gram per dl, my treatment is not adequate, or the patient is not taking the supplements properly. My target is to raise the hemoglobin by 1 gram per dl each and every week until the hemoglobin is normal, which usually becomes normal by 1 month. This is a very favorite slide. Examiners like to ask questions from this slide. So, response to iron therapy. Today I am giving iron to someone. Within only 24 hours the parent will say the child is feeling well, the child is eating well. So very commonly we get patients, bachchar khide hocche na. We give iron, the response is quite good. Okay? Because it will work on the enzymes first. The repletion of intracellular enzymes manifested as sense of well-being and increased appetite. Within 1 to 2 days, if the bone marrow is examined, there will be erythroid hyperplasia. Because the bone marrow is working, my erythropoiesis is increasing. So within 2 to 7 days, peripheral blood reticulocyte count will be more. And around 4 to 30 days, there will be rise in hemoglobin, and 1 to 3 months, the ferritin will rise. So to replenish ferritin in the body, we will have to continue supplementation till minimum it is 3 months. As per OPGI textbook of pediatrics, it is 4 to 6 months. Okay. So 0 to 1 day, 1 to 2 day, 2 to 7 day, 4 to 30 days, 1 to 3 months. এটা একটু মুখস্থ করে নিতে হবে, ঠিক আছে? Actually today's class is quite technical. Many slides are there which you won't be able to answer unless you learn it by heart. So you will have to take the book, take a piece of paper, learn and write, then only you will be able to remember these figures. It's very technical. Hematology is actually a very technical subject. Okay. So what are the reasons for non-response to hematinic therapy for iron deficiency anemia? If there is poor compliance with therapy, because iron actually tastes very bad. That's why children don't like it, even the pregnant mothers, they also, because antenatal mothers are supplemented with iron, they also sometimes don't want to take it because iron causes gastric irritation, the taste is very metallic, that's why the compliance is sometimes, mostly it's very poor. So each and every visit we will have to say, no, take iron, it's important. Okay. So the first point is only poor compliance because this is the most common cause, poor compliance with therapy, inadequate dosing. Then poorly absorbed iron preparations, example the enteric coated tablets, their absorption is not proper. Use of antacids or H2 blockers causing achlorhydria, because if gastric acid is less, iron absorption will be less. Okay. If the patient is already on these antacids or H2 blockers and ongoing blood loss at a rate greater than iron absorption, associated other causes of anemia like vitamin B12 or folic acid. I have given iron, but underlying cause is different. The patient is also having vitamin B12 or folic acid deficiency. নিচে আরেকটা মেকানিজম অলরেডি চলছে, তো ওইটা না ট্রিট করলে শুধু আয়রন দিলে তো অ্যানিমিয়া সারবে না, তাই না? Then malabsorption conditions like celiac disease, Giardia infection, Helicobacter pylori infection, inflammatory bowel disease, autoimmune gastritis. Then underlying hemolytic anemia, inflammation, infection, sideroblastic anemia, congenital cause, এটা একটা genetic cause হয়, the name is TMPRSS6, the rarest cause, that's why it has been mentioned in the last line. This is a transmembrane protease serine 6, just remember there is a gene which encodes for this protein. This is an enzyme, transmembrane protease. If this is defective, iron absorption doesn't occur properly. In that case, whatever iron we supplement, we are giving very huge dose of iron. Iron is not getting absorbed. There is a term called refractory iron deficiency anemia. This is the cause of that. IRIDA. It's a postgraduate topic. It's not mentioned in UG textbook. But that is a genetic cause of iron deficiency anemia. However iron you supplement, whatever you give the supplement, that is not going to work. Then a patient who is having so less amount of hemoglobin, we have no option, we will have to go for blood transfusion. Usually in IDA, we don't give transfusion at all. But we will have to see the situation. If the child will have to undergo urgent surgery, or the child is profusely bleeding, or there is severe anemia, the child is in congestive cardiac failure, hemoglobin is 3, will you just supplement iron? The child is having severe respiratory distress, the child is in congestive cardiac failure. But there is an important point. In severe anemia, we should not give PRBC rapidly, that will worsen the failure. That will be given very slowly, and we also give a mid-transfusion diuretic dose. So already the patient is in failure, we give huge amount of PRBC, the formula is 15 ml per kg for normal children, it's around 10 ml per kg for this anemic patient. Sometimes we give even 5 ml per kg also, very slowly. Otherwise there will be fluid overload and the child may die because of heart failure. And obviously monitoring the child. Now MCQ, the last year, black shirt ওই ছেলেটা বল, recommended duration of oral iron therapy, answer. তুই তো পারবি জানি, you last year তো হ্যাঁ বল কত ডিউরেশন বল, শুনতে পাচ্ছি না। দেখ চারটে অপশন, যেটা মনে হচ্ছে বলে ফেল, ভুল বললে আমি পরের জনকে জিজ্ঞেস করবো, পরের লাস্ট বেঞ্চে যাবে। শুনতে পাচ্ছি না। 2 to 3 wrong. Next, white shirt. 4 to 6, right. Okay. Nail changes in iron deficiency. I know all of you will be able to answer. The red t-shirt, the boy in red t-shirt, answer. Stand up. What will be the answer? Nail changes in iron deficiency anemia. Which one? All. Okay, right. Okay, you tell me, what is Koilonychia? Spoon-shaped nails. Okay. Then RBC in peripheral blood smear in iron deficiency anemia is microcytic hypochromic or microcytic normochromic or normochromic normocytic. Which one? Microcytic hypochromic. ওকে, আচ্ছা এবার একটু সামনের জনদেরকে জিজ্ঞেস করি, তুই বল। এটা আমি আর দেখাবো না, আই এম ফ্রেমিং ইট আপ ইন মাই মাইন্ড বিকজ আমি আগে ক্লাস শেষ করছি, ঠিক আছে? What is the amount of hemoglobin which will rise when a child is on iron therapy in 1 week? মানে 1 week 1 gram per dl, very good. Blue, তুই দাঁড়া। Tell me a cause of when you are giving iron but the iron level is not rising. There is poor response to hematinic therapy. Name one cause. The last slide I showed. আচ্ছা, ওকে ঠিক আছে। মোস্ট কমন কজ যেটা বললাম, পুয়ার কমপ্লায়েন্স টু ওরাল আয়রন মেডিকেশনস। ওকে, লাস্টে তুই বল। না তোর পাশে, তো রোজ ক্লাসে আসে প্র্যাকটিক্যালে, তুই বল আমাকে নেম 2 প্যারেন্টারাল আয়রন প্রিপারেশনস। টু নেম আই টোল্ড 2 প্যারেন্টারাল আয়রন প্রিপারেশনসের নাম বল। না, ফেরাস সালফেট তো ওরাল, প্যারেন্টারাল বলেছি। হ্যাঁ, কি এটা কার্বক্সি বলি, ফেরিক কার্বক্সি মল্টোজ। আরেকটা মনে আছে? ঠিক আছে, আরেকজন হচ্ছে, তুই বল আরেকটা নাম বল, কারুর মনে আছে? এনিওয়ান? আয়রন সুক্রোজ শুনতে পেলাম, কেউ একজন বললো।